Yes, so thank you for staying for this session on multidisciplinary care. I'm Barry Byrne from the University of Florida, and I have also the pleasure of serving in the MDA as the Chief Medical Advisor, where we focus over 150 care centers across the U.S., focusing on multidisciplinary care. So it would be great to hear from our speakers who are having a conclave over there on the side. Here they come. And we're going to go through these three areas: endocrinology, GI, and neuromuscular care. And I'll fill in where necessary and anything related to cardiac care, which is in my particular area. So I'm going to let each speaker kind of introduce themselves and go through their slides. We'll get these queued up. So Kent, you want to go first? That would be great.
Sure. There's me. So basically for GI, what we do at our clinics is we really try to focus more on trying to maintain an active life. A lot of people get scared when they start talking about GI issues for a lot of various reasons. A lot of people don't want to talk about GI issues too much for some reason. I don't understand. It's just a lot of crap. I mean, come on. We want to maintain an active life. We want to try to minimize dependence on others. And there are ways that we can do that. A lot of people don't think about G-tubes or bowel regimens as trying to improve quality of life. They think of, oh my gosh, no way. But it actually can really kind of free up how you do things, because you have to deal with it. Particularly when you take trips to like Florida. You have to think about how you're going to get the nutrition. And then you got to think about how you're going to get it out. So in our clinics, we start at a very young age. It's been studies showing that actually issues with feeding and bowel regimens occur at the very young with these kids, but it's not so much probably from the muscle problems, but maybe more from the sort of comorbid behavioral and developmental issues that go along with it. A lot of sensory issues, anxiety, autism-like features. And then as I develop relationships, we start talking about, okay, as we meet, we're going to talk about, especially as you get towards more the preteen, teen years, how are you eating, how you get into the bathroom, and start getting into more of the details that might start slowly creeping in. So we always talk about bowel regimens. We don't treat constipation. I mean, I can treat constipation, but that's the last thing anybody in a wheelchair wants treated. Because if I'm treating constipation, that means you got to go poop. And if you got to go poop in a wheelchair and you're in a classroom, you're at a family function, it's the last thing you want to do. So we try to talk about how can we best come up with a bowel regimen to keep you active, to keep you functioning. Maintain a good colon health, because that's very important. Early on, if you kind of start just withholding or not having, if you're having constipation issues, a lot of young guys will start showing up with a lot of colon problems because it's built up over the, all pun intended by the way, because it's built up over the last few years and stretched things out. And we try to minimize the worry. We don't want you having to worry about having to go to a bathroom if we can avoid it. And then maintaining the nutritional intake. We'll ask, we want to prevent malnutrition. We don't want to start using G-tubes to prolong life. No, we want to use G-tubes to help maintain good nutrition and good active life. Because there are some early data showing that if you start to have malnutrition, if you start losing weight, you're going to exacerbate and hasten the decline of your cardiac and pulmonary function. And again, the idea, maintain activity, keep you going. That's it.
So now Nate's going to talk about some of the considerations for pediatric endocrinology care, and which is obviously important to all of you, so your boys maintain their optimal bone health, height, and endocrine function. So thanks for being here. And then we'll really want to be interactive and take questions after we get through these original information.
All right, thank you so much, Duchenne, and for including me today. So my name is Nat Nasomyon. I'm from Cincinnati Children's in Cincinnati, Ohio. And as endocrinologist, my role in a team is working alongside neuromuscular specialists and other team members helping care of individuals with DMD. While we know that steroid is very important, it's worked well in stabilizing muscle inflammation, it does come with side effects as well. And my hope today, I'm quite ambitious. I'm going to cover 5 topics today. So let's start with osteoporosis. This is a topic that's close to my heart. This is actually how I get involved in DMD care. This is my primary interest. So why is osteoporosis important? It can lead to a fracture of the spine, and it can create a lot of back pain. It can make you lose the height and also affect breathing. Fracture of the legs and arms can also cause chronic pain and also can lead to permanent loss of ambulation. And that is a life-threatening complications called fat embolism as well. So the current care considerations from 2018 recommends a routine screening, make sure that we get enough calcium and vitamin D from diet. In terms of screening for osteoporosis, we should be doing DEXA scan to check bone density and also get a spine x-ray at least every 1 to 2 years during on-steroid treatment. And in terms of the treatment, there is a bone strengthening medication called bisphosphonates. The care consideration recommends to start this treatment in an IV form when there is moderate or severe fractures. However, we know that this measure is not enough. A lot of individuals with DMD still continue to fracture. So I think there are 3 points in the process of osteoporosis that we can be proactive and start intervening. So the first step, I think at minimum, when there is already evidence of mild spine fracture, treatment should be started. Being more proactive, we could also start treatment even before fracture happening when the spine starts losing height. And we also hopeful about the newer steroid that you have heard just recently, that it may be more gentle to the bone. So here is the example of the x-ray of one of my patients. So this patient started steroid at age 6 years old. This is his x-ray at age 9. And then by age 12, you can see that the spine height decreased in general, even though this is not qualified as a fracture yet, but we do recommend starting bisphosphonate treatment. In our center, we started with oral bisphosphonate, which is taken once a week. And we had shown that this measure actually stabilized bone health in many individuals. For example, this patient 7 years from the treatment start, the spine height remained very stable, no new fractures, bone density also improved over time. While majority of our patients have stable bone health, some still develop worsening fracture, as you can see on this x-ray. You can see that the spine height decreased significantly. So in this setting, we do recommend switching to IV bisphosphonates. So the second topic is about weight gain, and we know that this is part of the decrease in physical activities from decrease in muscle strength, and the steroid itself also increased the appetite as well. So this has a complication which may include prediabetes, high cholesterol, high blood pressure. It also limits the mobility, ambulation, also can create obstructive sleep apnea, and also can impact in quality of life. So the care consideration recommends routine assessment by nutritionists with the goal to maintain body mass index within a normal range. The whole family should also adopt a healthy eating habit, not just individuals with DMD, but as a whole family. The care consideration did not talk about medical interventions. However, in the past 2 to 3 years, there's more and more weight loss medication approved for children and adolescents now down to age 12 years old. For the interest of time, I'm going to talk about metformin. This is the medicine that many may be familiar with. This is the medicine that used for type 2 diabetes. It's come in a pill taken once or twice a day. and it works by increased insulin sensitivity. And in Cincinnati, we use this medicine early on as a proactive measure when there's evidence of excessive weight gain and also blood level that shows insulin resistance. So we had shown that the use of metformin, even though not making individuals with DMD losing weight, it stabilized the weight trajectory pretty clearly in a group of 45 patients seen here. So before metformin started, the average weight gain was 16.5 pounds. On metformin therapy, on average, there's no further weight gain on treatment. So I think this is something that can be considered early on in the stage of insulin resistance and weight gain. The third topic is about growth. So this is the classic growth chart of our patients with DMD. As you can see that prior to steroid start, the average height gain should be about 2 inches per year. With steroid on board, the growth velocity declines significantly. The care consideration recommend routine check in height every time you come into clinic. And when there's evidence of growth deceleration or slower growth, additional workup should be considered because individuals with DMD could also have growth hormone issues, could also have thyroid problems affecting that growth. In regards to treatment, there are several options. For some individuals and families, height is not a major concern for them, so we could opt to just keep monitoring. We could also talk about potential treatment with growth hormone. However, this is going to be quite a long discussion as the family and individuals with DMD need to weigh about the risk and benefit of growth hormone treatment. The new steroid vamorolone has shown some promising result on growth. It seems to protect the height loss during the treatment, so we're still waiting for more data. The fourth topic is about puberty. So puberty tends to usually happens around age 9 to 14 years in boys, and this is a result of testosterone increase. It's definitely make the body develop further changes and maturations, also increase muscle mass and growth spurt as well. Delayed puberty is defined when there's no signs of puberty by age 14, and this is very common in individuals with DMD. We also learned that even with people who went through normal puberty, testosterone level can actually be lower in young adulthood years as well. So one thing that I would like to add is that young adults with DMD, I believe that testosterone should still be monitored. Why is this important? Because we have way to treat. Testosterone replacement has been shown to improve, promotes physical maturations. It has also been shown to improve bone health as well. The last topics, very briefly, since we're going to have another hour after this session, talk about. So for adrenal insufficiency, I would like everyone in this room to be aware of 3 things. So first, we should know about signs and symptoms of adrenal insufficiency. It can be very non-specific, so we need to be cognizant about this. Another things that we need to remember is to discuss with your care team about stress dose steroids. And this may be in the form of the emergency injection kit or also medical alert. When individuals with DMD visit emergency room in a local or community hospital, the medical team should be alert as well that we are on chronic steroid treatment. And the last thing is that the steroid should not be stopped abruptly because it can create adrenal insufficiency. So just to summarize, we talk about proactive ways that we can optimize bone health. In my opinion, I think bisphosphonate treatment should be started early on in the process of osteoporosis, not waiting until severe osteoporosis happens. The newer steroid, vamorolone, have show some initial promising data about bone marker as well. We still wait to see the longer term data on fractures outcome. In terms of weight gain, the healthy eating habit is still a cornerstone of weight management. If there's questions or interest about weight loss medications, you can discuss with your care team as well, knowing that there are several options available for us now. In terms of growth, again, I think the newer steroid have shown some promising data. In terms of puberty, testosterone treatment is strongly recommended when it's indicated, and testosterone level should be monitored as well. All right, I would end my talk now. Thank you.
Thank you so much. Really, really important issues, and we'll, I think, get into some more details in the Q&A part. And now Arvind is going to talk about the role of the neurologist in care. If we can advance a couple more slides.
Okay, let me just keep moving. Okay, here we go. Sorry. Oops. All right, thank you guys. Thanks. This is my real name. It's Vera Pandian, but I also go by Panda. I am from Arkansas. Is anyone here from Arkansas? I know there's one right here. But have you guys heard of Arkansas? Anyone heard of Arkansas? It is in the United States. All right. So I'm a neurologist there. I know you guys have seen this multiple times today. DMD is not just one thing. It's not just a muscle disease, right? It is a multi-system disease. And every single specialist and every single member of the team is important to provide the critical care that's needed for them. So as a neurologist, what do we do? Most of the places it is a neurologist. At some places you may have a rehabilitation medicine doctor kind of runs the whole show. In some other places, maybe a cardiologist who will be doing that. But in most places in neurology, you need this one person to spearhead this whole multidisciplinary or comprehensive aspect of the care. Now, this is kind of some of the, the actual ideal goal for us is to collaborate with the multidisciplinary team to provide the comprehensive care, keeping in mind this individual boy. I guess every person's needs are different and the goals are different, so we have to manage them based on that. Now, we do have some care guidelines. I know this is small. If you look at it, it was published in 2018 or a few years ago. If you look at this, the role of neurologist wasn't that much, right? So I used to say jokingly, if you have good team members like here, neurologists pretty much don't do anything, just to make sure they do their job and they're good, right? But now with the advancement of the therapies available and all the upcoming trials and research, there's more to the stuff that we do in the clinics. So one of the first thing, obviously, we talk about is after the diagnosis, the treatment options, right? The steroids. You guys heard from about different steroids in the previous session, about the Emflaza, about the vamorolone Agamree. So I think, and then you have prednisone. Prednisone is not FDA approved, whereas Emflaza and vamorolone are approved for 2-year and older boys with Duchenne. And however, the prednisone and Emflaza do have a benefit of, we have been using that for years and years, so we have years and years of data compared to vamorolone. Now, some of the questions and things that we discuss is when to start, right? Previously, when you talk to, it's still, the practice is different. Overall goal is start before you see the decline, but sometimes, most of us, I do usually start at early age, like around 2. And then some people start at 3 or 4. If you're starting at 2, then the question is, what dose do you start? Do you do a daily dose, or you kind of do a weekend dosing or alternate dosing regimens to keep the side effects profile low to begin with? So I think that's, again, a kind of a discussion that you would have with the neurologists on the team and the multidisciplinary team, right? For example, our endocrinologist mentioned that for growth and puberty, for growth and the bone, vamorolone might be better, but from that perspective, that's the case, but you have to put the overall kid in the picture and kind of take other issues and to kind of fit what would be a good fit for that particular boy. So then the discussion will be which steroid to start, what the dose, and then what happens when an adverse effect happens. Do you switch them? Do you stop them? Do you do an alternate dosing, like weekend dosing, or some people do 10 days on and 10 days off of steroids? So all of that. And then another question that comes up is, what does it do when boys stop walking? Is it okay to continue the steroids? Do we stop them? Again, that's also a risk-benefit discussion that you have to have. Something is better than nothing. Keep them on some steroids is actually better lifelong. But again, you have to weigh the pros and the cons before you make the decision. And then we'll get into that questions also. Then there are, if you're doing the exon skipping therapy or the gene transfer therapy, can we stop the steroids after that? I think the easy answer is no, because I don't think we have any data saying that these are cure, because none of these treatments that we have in hand is a cure. They are going to slow down the progression. And we know steroids do work. Now the question is, can we optimize the steroid regimen, maybe decrease the dose or switch the regimen before, rather than completely stopping it? So that's another discussion that you would have with your team. Now, another drug on the market that was recently approved is the givinostat, which you guys also heard from the previous session. And this is also becoming the standard of care. It's approved for boys that are 6 years old and above. So again, it does show the functional improvements in these boys in the clinical trial. There's also some adverse effects that I mentioned here. So again, it's also going to be individualized, discussing the pros and cons, and then decide. Now, moving on to the new set of therapies that are, I say new, but some of these exon-skipping agents have been out there for a few years now, right? These are dystrophin-targeted therapies. As you know, the culprit here is the lack of dystrophin in Duchenne muscular dystrophy, right? So how are these targeted therapies do? So we have 4 of them that's approved in the market. Again, the question is risk versus benefits, right? All of these that we have in hand are once-a-week intravenous infusion. And how much of benefit that they have, how much of dystrophin that they're making based on what we know. So take that into consideration. And again, should we start? Not everyone is eligible for exon-skipping agents, right? Then the discussion would be keeping your pros and cons. Should we start all of them, or should we just wait for a better one? Then also the same question, should we stop steroids once we start the exon-skipping agents? My general recommendation is no, because I've tried that in the practice and I've seen decline after stopping steroids. I usually say no. Then again, I think these are some of the general themes that you have discussions with your neurologist. I think most of you guys know about this. I'm not going to get into details how an exon-skipping agent works. I'm just going to skip these. If you have questions, I can go back to these slides later. Now, we talked about the ones that are approved, and then there are several of them in the pipeline. Again, this is it's challenging, good problems to have more options, more clinical trials to come. Then it's also a discussion that you would have in the clinic. Should I go to this therapy, or should I get into the clinical trial that if you're already running, right? So these are your exon-skipping agents. We also have the second generation or newer generation exon-skipping agents, or what we call PPMOs, which are more of, with your currently available ones, you do once a week. These ones, it could be once every couple of months, once every 3 months. Again, something to consider. Then your dystrophin gene transfer therapy, right? So we have one of them approved, which is the delantestogen moxeparvovec for age 4 to 5 year old. Again, same discussion, risk versus benefits. Should we start or not? Should we wait for a better therapy to come in the future? Or should we consider another clinical trial? All of these discussions would happen, and you would, again, taking into pros and cons with your individual boy before you decide, and same thing with the steroids as well. And again, not going to get into details. It's just delivering as microdystrophin, a miniature version of dystrophin protein. You put that inside a virus and you inject. It's a one-time intravenous infusion, and there's a lot of safety associated with it, and there's intense monitoring after that for at least 3 months. This is just giving you a schematic picture of what happens. You have this, what we call these 3 that you have, we call them DNA cassette. You put them into the virus, the vector that you're using. And there are multiple programs that are looking into the gene transfer therapy. One that's approved, there's Regenex by their Solid, Roche, and other programs in the pipeline that they're looking at the gene transfer therapies. Then you guys know there's also for the kids with nonsense mutations, there are companies looking at the stop codon read-through strategies like ataluren. Then there's also genome editing or CRISPR that's in the pipeline. There's a lot of options out there. The key is discussing this with the neurologist, with the team, and decide what's better for your kid or for your boy. Again, this is some of the non-genetic targeted therapies. Some of them you had discussed previously in the previous sessions. Again, just to keep in mind. Now, these are different therapeutic strategies that are out there that's being studied. Some of them are approved, some of them are being in the clinical trial phases. Always to keep in mind when you have these discussions. Now, this is something that's very close to my heart. I don't think, like I said before, none of the therapies that's available out there is a cure. Our future is going to be, whatever you call it, combination or sequential therapy, that's going to be the future, right? Either combining the gene-targeted therapies, either giving you gene therapy, and then if your kid is, or if your boy is eligible for exon skipping agent, then combining with that, or maybe another non-genetic targeted therapy, maybe a gene transfer therapy along with something else, like like your givinostat or Capricor or Edgewise, some of those. So I think that's going to be the future. Again, there's a lot more data needed, but that's where we are heading, and I think we already have this experience in some of the other diseases like spinal muscular atrophy. So I think this is going to be the future. I think this is also very important. Again, we have talked, there are a lot of options out there, a lot of medications, trials. I think the key here is establishing the goals of treatment. What is your goals of care? That goals vary from patient to patient, or from one individual to another individual. Some of them might be in the ambulatory phase. Some of them might be in the non-ambulatory phase. So what is your goal? What are you trying to achieve? I think that's establishing that upfront is extremely important when you have the discussions with the providers. The other thing that we talk about, again, I'm not going to get into details here, either the transition planning. It's always, there's a lot of adulthood. So your neurologists kind of play a role in discussing the transition planning as well. Again, the care models vary. Again, once you get into the adult side, it's completely different. You may not have this multidisciplinary, due to various reasons. You may not have the multidisciplinary team, like you go there one day, see all of them. Sometimes patients don't prefer that either. They may want to just see one provider at a time and then see someone else the next day. So there's variability in practice. As long as you get established with all the necessary providers that you need, I think that's important. Then, as you all know, the multidisciplinary clinics, how they work, it varies also. Most of the times you come in, get the test done, and you see all the doctors the same day. It's a long day visit. We try to being more creative to kind of make that day more interesting. It doesn't work. When we did at least we did survey throughout for all the families in the United States who are going to major centers, the majority of them actually prefer to even drive long distance to do this multidisciplinary care rather than being local and seeing multiple different providers. All right, I think with that, I'm going to stop right here, and we will be happy to take any questions. Thank you so much.
Thank you so much. I want to use your last slide to launch into some questions and ask the audience, because there are a critical shortage of people trained like Dr. Panda, we've relied in many cases on advanced practice providers. So among the audience, how many of your kids see a nurse practitioner or a PA in the context of their multidisciplinary care to provide care coordination? Many? Some in the back. So I think, and in your practices, do you have advanced practice providers in your team?
Yes.
Yes? Sometimes? So in our practice here in Gainesville, just up the road, we actually have 3 advanced practice nurses just focusing on neuromuscular care, in part to really ensure that there are no gaps in the care, because they're really good at that, and they have become, in effect, somewhat the new team leader. I think we're now in an era where we relied very importantly on neurology to make the diagnosis of Duchenne, and now we're entering an era where I think it came up this morning about Ohio initiating newborn screening, but it's actually now also underway in New York and Minnesota. And even though the federal recommendation has not been published yet, some states actually have a requirement to make a decision about that within a fixed time period after the federal recommendation is anticipated next month. And so you'll see an increasing number of circumstances where children are diagnosed early. We've seen this in other diseases. When the newborn is identified, their older sibling might therefore then also be identified through newborn screening and family testing. So we're going to see the testing the diagnosis shift from the clinical diagnosis to pre-symptomatic identification of patients, and that's where we'll actually engage with families sooner. There'll be more burden on the healthcare system as those boys come to receive care at an earlier age. So how do you think that'll impact in your practice if you had a steady cadence of newly diagnosed patients that were infants?
I think that's going to be a challenge, right? So I think we know there are some phenotype-genotype correlation, right? So when someone tests positive, high CK, then you do genetic testing. There's an out-of-frame mutation. We know it's Duchenne. Then you talk about what are therapies I can actually do now to help them, right? So if that kid is actually eligible for an exon skipping agent, I would probably start them as early as, we have done as early as 6 months, 3 months also. So then also from an early intervention services standpoint, it's important for them to get evaluated and get the services as soon as possible. I think that would be helpful. Of course, the gene therapy, there are trials looking at the younger kids, but not that young. And also the one that we have approved is only 4 years and older, so it may not be applicable in that part. Steroids, I usually start them at age 2, so not in the little neonates or infants. I think another challenge is going to be let's say if you have an in-frame mutation, then it's going to be hard to predict who's going to be getting into a Duchenne phenotype versus intermediate phenotype versus a Becker phenotype, kind of similar to the Pompe's challenge that we have.
Yeah. So in Kent, what portion of, you may see patients who have an elevated transaminases through some other, screening for some other reason, and then they come to the GI clinic. Is this often a reflex in your practice that they'll also be seen by the neurologist, or we hear often stories of children who get worked up for liver disease until ultimately the CK is tested and they're determined to have a muscle disease?
At our institution, pretty much any young child that comes in that looks relatively healthy and has elevated liver enzymes, we usually get the CPKs, the CKs initially.
Yeah.
So in our institution, I don't think we'll be seeing people being delayed from a liver standpoint. It may actually, in our institution, it's usually more being able to early identify.
Exactly. So how about questions from the audience about approaches to multidisciplinary care? Go ahead. Is that Mindy? Yes, it is.
Glad I got to make you run, Jennifer. I want to talk about transitions of care for adults. We're going to have more newborns than ever trying to get into the pediatric clinics. We have more boys living longer. We have more adult patients. We have overburdened clinics. And right when they start needing more care, our care falls apart. So I think we have to make adult multidisciplinary clinics a top priority. We can talk about treatments, we can talk about potential cures, but we have a generation of boys right now that are falling through the cracks. I'm in the middle of it right now with a 22-year-old. His cardiology's here. I don't have a neurologist right now because we got kicked out of our clinic. He's 22. We can't see him anymore. So, we have our first appointment with the adult neurologist next month. But, that's just one specialist. No one's coordinating our care anymore. We've got different providers with different, contracts with insurers. It's a mess. So we've got a lot of adult patients that have nowhere to go for care.
No, I wanted to bring up that point because we will see this shift towards earlier diagnosis, but we're also, in some ways, the good news is we now have boys with Duchenne becoming young men with Duchenne who have to transition. In some cases, in a pediatric hospital, probably is the case in your institution, that over 18, they can't be seen there anymore. At least at our a hospital, within a hospital setting, we can see patients up to any age, and then we work on a 2-year transition plan. But this relies heavily on the advanced practice nurse team, and we're also starting to rely more on the PM&R group who has expressed an interest in the transition of care. And we've developed, through EPIC, a transition of care navigator that helps establish when a child's around 15, that discussion begins, and that we try to see those patients concurrently, because that handoff is very difficult. And exactly as you said, care only becomes more complex in the older ages. And unfortunately, our adult counterparts are not used to this model. So it's going to be a long period of education and acceptance from them that every patient needs to be included, that they need to accommodate this model, because I do think it really translates to better care.
I think the challenge is multi-layer, right? So one, the actual providers per se, to finding providers who are interested and do that. But I think that's been changing now with more awareness and more fellowship training being included in that, right? The other challenge is convincing the administration to actually do these multidisciplinary clinics. The goals of the mission of a pediatric or children's hospital is completely different than an adult-run hospital, because they may look at how many, we call them RVUs, or how many patients that you see a day. Obviously, if you're doing a multidisciplinary clinic, it's not going to be possible for a cardiologist or a pulmonologist to see 15, 20 patients a day, where in their own clinic, they may be seeing more than that. I think I see this, I think the pediatric team has to take the responsibility of educating the adult team, identifying the provider, helping them set up this multidisciplinary clinic. How to overcome that administrative hurdle is one, and the other thing is also how to overcome the payers' policies surrounding the pay, how they're going to get reimbursed and all of that from the visits. Because I do hear that once you get an adult, if you're getting physical therapy in the community, the physical therapy visits that you're doing as a part of the multidisciplinary visit doesn't get reimbursed, or it doesn't get counted. So there are some examples like that needs to be ironed out also.
And just to make one more comment, I mean, it's harder to get these older guys into the clinics. So not only are we not getting to see all of our care providers at one go, we're having to get these guys transported to the clinics multiple times. And I think we should stop calling it a pediatric disease as well. Yeah. Look around. We have a lot of adults now.
One way we address that, and you certainly should advocate for your guys to consider this approach. If one of the providers is not available in person when we have a patient on site, because there may be some advanced testing that's done, it's hard to get your echocardiogram or EKG at home, but that other provider, we have Zoom into the room and keep that schedule so that some visits may be hybrid. And then we can also, people that are coming from a distance, we may alternate with their local providers the more subspecialty care that they would receive at our center. And I want to advocate that all of you ask for that you have local care providers in addition to your go-to specialist who you've developed a relationship with for any particular problem. But it's really important to have both local and your expert team, because in Saturday night, at 2 a.m., you can't go off, 3,000 miles away. So it's really important that you have that network of care.
Just want to add one thing about neurologist comment. I know in the past we used to say once you become an adult, you really don't need neurologists, but I do think now you do need them with all the therapies coming up. They're the only ones who can at least work on those prior authorizations, paperwork, get your Emflaza coverage, or Givinostat comes up if you need to work with insurance. I think it is important to have them with the advanced therapeutics coming in the pipeline.
And then I think we don't know what the future is in terms of the combination therapies. Right. As you mentioned, we will really ultimately change the timeline and phenotype. I don't think we're there yet in the sense that any one of the infrequent treatments or like a gene therapy treatment will be a lifelong transformative cure. Maybe we'll get there someday, but that's going to mean the adult providers need to be very familiar with this new phenotype of where there's been improvement in key critical domains, but not in all of them. There may be sleep problems. There may be additional issues around the pulmonary care that is not represented here right now, but those cardiopulmonary issues are important. I know in my own experience when we had more severe heart disease without adjunctive therapy in the patient population, if they were being transferred to adult cardiology, it was often for end-of-life care, which was just really not the way to engage that provider population. They need to get to know these young men before any of those issues are really being discussed. So, question over there.
Yeah, so I was going to bring up the, care for adults also, but so as far as with the MDA, they had coordinators at the MDA clinics, and they've gotten rid of all those coordinators to, I guess, to save money, or they used to have local offices at all those.
Yeah, the pandemic was really challenging for many multidisciplinary clinics, and maybe we just think about how we've learned from that experience, particularly how people worked remotely. Now we can, and sometimes their attendance is virtual because they cover a greater territory. But Don Wood has been very strong advocate of getting those people back to support families in any way they can by increasing that staff in the Innovations in Care group within MDA.
And some of those.
Other questions out there? Yes.
In the back.
Is it okay to switch from the Deflazacort to this new one, the Givinostat?
There's a question about switching meds. Panda.
So I think, I don't know if you can consider Givinostat switching from Emflaza to, I think that was a question, to Givinostat.
Yeah.
I think Givinostat is not a steroid, but the studies that they have done is actually on boys who are already on steroids, so I wouldn't consider this as a steroid replacement.
So from the steroids, which one you would consider the less toxic one? Because maybe we could switch from the Deflazacort, for example, to another
So it's a tough question. I think it really depends on the need, the individual goal for your one specific individual, right? So there's prednisone, there is Emflaza, and there is vamorolone. There are some differences. If you look at the vamorolone Augamry, they had compared it with the placebo, meaning the boys who are not on steroids, and also with prednisone. There's not a lot of comparison with Emflaza, but we do know the vamorolone with the newer steroid, vamorolone Augamry, it's better for your bone. There's decreased risk of vertebral fractures, and also it's better for keeping the boys taller. Those are only key differences. In terms of behavioral problems, it's better than prednisone, but there's no comparison with Emflaza. So I think there's a lot of nuances that you have to take into consideration when you make those decisions in terms of which steroid to choose for one particular boy with Duchenne.
So if we do so, we would be able to participate in gene therapy, for example? If we switch from the one to the other?
Right, so that's a great question. I think that depends on the gene therapy. If you're talking about the clinical trial research, that depends on the individual sponsor, the individual study. There are some studies who wouldn't take, they haven't looked into the vamorolone yet because it's just brand newly available right now. So they may not include you if you're on vamorolone. But if you're on prednisone and Emflaza, you may be able to. But also, most of the studies for gene therapy, you have to be on this proactive immunosuppressive steroid, which is prednisone, that's given on top of your baseline steroids that you're already taking. And in those, almost all of the studies right now, they're using prednisone. So no matter what, if you're on a standard of care, prednisone or Emflaza, you have to be on additional prednisone or prednisolone for about 3 months around the time when you get the infusion.
Period of time.
Also, for the HOY study, they mentioned for the kids to be in gene therapy in prior. Is this right, that they have to be in gene therapy before participating for kids over 14 years old?
I'm sorry, can you repeat that question?
For the HOYs study, study, they mentioned that the kids have to be in gene therapy in prior of participation, if I understood correctly.
So age-wise, I think there is a separate study that they're doing on post-gene therapy boys who receive gene therapy. I think there are some specific inclusion-exclusion criteria for that. You have to be at least 2 years out if you want an open label gene therapy study, or 3 years out if you're on a placebo-controlled study to be eligible for that. There's also an age-wise study where you have on any boy with Duchenne who has not received gene transfer therapy.
Okay, and the last question is, how do we identify an asymptomatic back fracture?
I'm sorry, can you repeat? Thank you. So this is actually a very important question because actually about half of spine fracture have no symptoms. Okay, so that's why we do recommend screen with X-ray every year at the time of steroid starts, even without symptoms. But when you develop symptoms, a lot of time I hear, people will complain that they sometimes heard pop sounds, after a fall or certain position change, and that followed by back pain. So that's quite common symptoms too.
Thank you.
Other questions this side of the room?
What's the question in the back, I guess?
Can you hear me?
Not yet.
So I have
There
a
we go.
question actually towards both the adrenal and the GI. Is that getting passed along everywhere? Because we are running into an issue, constantly told that is not Duchenne's, that is something else. Here's how we're going to fix it. Let's go on Miralax. And then last year we ran into a problem where he suddenly lost a lot of weight. Nobody has any idea why or how, to the point he developed SMA syndrome. So they are like, okay, G-button now. And then within 6 months, we are no longer able to pass stool. And now we have the sacostomy. I can never pronounce it correctly, but it's the one through the appendix. And so now we have both of those things happening. And everyone's like, oh, yeah, no, it might be the Duchenne's now. And I'm like, we're 17 years into this game, and we're just now being told that maybe it's Duchenne's. And when we bring it up with neuro, they're like, oh, well, maybe. But we do not have GI involved in the clinic at all. I'm not real sure if we have anyone that would be part of adrenal at all on our clinic. We've not seen them. But I'm just curious if that information is being spread, because we're not seeing it in Texas.
Yeah. So let me just verify. So your son, you had GI issues early on. They tell you it's not due to Duchenne's. When he gets to teen years, starts having problems, like, okay, maybe it is Duchenne's. And then your other question is, or what you're bringing up is, are there other clinics with GI people in them? So, as I said earlier, each child is different when they're early on. We don't see a lot of GI issues associated with muscle issues in the first few years of life, developmental issues that are associated with Duchenne's. But the problem there is, as in any muscle that gets stimulated and used, you will eventually cause muscle loss. So if you're struggling with feeding issues, vomiting, and the biggest one, of course, is constipation. And mildly managed or just flat out not picked up early on. And then that leads to problems, severe problems later, because they weren't maybe addressed aggressively enough. It's one of those things, as I said earlier, people don't want to talk about GI issues. Even the neurologists don't want to talk about GI issues. I can't tell you how many times in my career I've had people tell me, oh, I know how to take care of constipation.
No, we don't.
No.
Can you say a little bit about how dystrophin deficiency might influence smooth muscle cell function related to swallowing and bowel motility? Is that?
Well, that's a great question because we really don't know. I mean, when I got started in working with Duchenne, so to go back to your other concern, like, is this being spread? There are, but most places do not. And I'll get referrals from other places just to answer these questions, and I'm very glad to do that. We are looking at, I am heading up a committee later this year to give more practical recommendations than what was given previously by the CDC and others, where they kind of just gave these general looking for. Now, to go back to your question about affecting the smooth muscle, we do know dystrophin's there, but smooth muscle is structured differently. It acts differently than skeletal muscle and cardiac muscle. We don't, I mean, anecdotally, I don't see a lot of gut failure of just like everything failing from muscular dystrophy. There are cases reported, and there are cases where they've done and they looked and they found that there was a dropout of muscle. Now, whether that was due to dystrophin, I don't know, because the funny thing is most people will retain their ability to swallow. The thing about swallowing is it primarily depends upon skeletal muscle. Once you get past the upper third of your esophagus, then it's smooth muscle. So swallowing itself is more skeletal muscle related. And the thing about it is I think we wait too long to really determine if someone's having feeding issues. The questions usually are, do you have choking, gagging? How long does it take you to eat? Are we spending 15, 20 minutes, or is it 30 minutes to an hour? And more importantly, of a mother or father, all I can tell you is those dynamics tend to lead to a person not eating as much and as well. They don't want to impose upon their caretakers. You just don't eat as well if you're able to feed yourself. And so once you start not being able to feed yourself, I think we need to be a little bit more aggressive of asking, watching the weights, because the problem is, up until this point, everyone's told you, don't gain weight. We want to try to keep you from being so heavy. So when you start to lose weight, everybody's like, hey, not me. Calories in, you're spending that, you're wasting that energy, you're going to start, as I said, most likely you're going to be starting to have an accelerated degeneration of your breathing, your pulmonary status, and your cardiac status. So losing weight's fantastic, but it's how you lose weight. If you're not getting enough calories in, you could really be making things worse. We don't have any great studies of looking at how dystrophin mutations affect smooth muscle. We don't really know if a lot of the issues with constipation, particularly as you get older, if that's more due to the dystrophin. But the problem is, again, regulation of bowels depends a lot upon you walking and being able to use skeletal muscles of your abdomen to be able to evacuate your colon. Once you start losing that, you start not being able to evacuate clearly, and then that over time builds up and causes issues.
Yeah, very good points, because, as you as parents, and the whole issue around time of feeding is something we've observed in other muscle diseases. People don't want to be a burden, and they then are excluded from the social starts a little sooner so that everyone can be participating in the meal there at the same time.
Because in our clinic, we start talking about G-tubes fairly early on. If you start spending a lot of time, if your eating starts ruling your life and you start making changes, we talk about using it to maximize life. For instance, if you're traveling, let's say you traveled here from Arkansas, and you want to be able to maximize your time, having a G-tube to give fluids, to keep you hydrated, having a G-tube to be able just to give a quick bolus of a formula, instead of having to find a place to spend an hour to feed.
Added as supplements, this is really important also for bone health and for maintaining muscle strength. So any last questions as we finish up this session?
How do you communicate with pediatricians? Because this is like first point of contact. Sometimes I feel there's a lack of education, especially outside the clinic, right? Like we are going with all our issues first to pediatrician. And how do you deal with that? How you spread awareness and connect to them?
I think it is extremely important. You bring up a very good point that to communicate to the primary care providers, and whatever we do as part of the clinic visit to the pediatrician, the primary care providers. Now the challenge is how much of it that they're receiving it and they're interested in learning and collaborate. And I think that has been a big challenge.
Yeah, and maybe it's important to make a point that there are other providers in the nutrition space, like registered dietitians. Make use of those resources if there's not a gastroenterologist in your community. They can certainly help with assessing caloric intake, understanding the need for any supplementation related to bone health, and support, you know, the overall care from the standpoint of the registered dietitian.
Yeah, in our clinic, I don't make the recommendations of caloric intake, protein, carbohydrates, and those things, or vitamins and minerals. I use a registered dietitians also for even just giving recommendations for fluid management. Because a lot of the kids start self-regulating fluids because they don't want to pee. And then you get into other issues. So we have to establish pretty clear guidelines of calories, nutrition, and fluids.
And there's definitely a need to educate our primary care providers, because there's a spectrum. I have had providers who would call and say, hey, this kid would probably, are there any clinical trials? Can this kid get into this trial? On the other end, I also have pediatricians who would call and ask, why did you start this kid on steroids? So I think that's a whole spectrum.
You know, I learned something from an occupational therapist here in Orlando. In fact, you mentioned reluctance for a school-age child to be going to the bathroom because they may not be able to open their pants. Something as simple as that, and who wants to have that situation in the classroom? So she told us a very clever idea that I pass on to a lot of families, that if you put a small loop of fishing line in a zipper, it's easier to put your finger there and don't need to ask someone for help at that stage. So, you know, little things like this, adaptive clothing, really plays into the whole.
But you got to have somebody know how to ask those questions too. And that's getting back to your point of trying to get GI. That's what we're trying to hopefully do, is get more poignant, not just recommendations for the families, but for the primary care providers. How do you eat? How do you poop? And I don't mean, do you just sit on the toilet and poop? I mean, is it part of your schedule? Who do you depend upon? How do you get from your chair to the toilet? Do you ever worry about falling, being dropped? Has your parent ever had rotator cuff problems or back problems? You know, you have to be very comprehensive in how you approach these questions to figure out what you can do to improve their quality of life.
We have two more questions back here. Do we have time?
Just wondering, sorry, are you guys finding that EOE is in conjunction with Duchenne for the GI?
I'm sorry, what?
Eosinophilic esophagitis.
Eosinophilic esophagitis. Is this something that you see at Duchenne?
Oh, eosinophilic esophagitis we see everywhere. So I don't see it necessarily. I've actually had a few kids that I thought might have it. The interesting thing about it, being on a steroid should be the treatment for it.
Yeah.
So, but I'm not also, I mean, we see inflammatory bowel disease. We see other things that are to be controlled by steroids that can still break through and occur in Duchenne patients.
All right, well, I want to thank all our panelists and thank you all for your great questions, so thank you.
I think we are good, right?
Thanks so much.
All right, guys, thank you. Thank you. Yeah, thank you. I'm gonna do a little. How about Dr. Byrne in this panel? Huh? This is fantastic. So how many of you have seen, I mean, I'm old enough to remember MacGyver. Doesn't it feel like we need to be MacGyver in our situations? So I heard Dr. Byrne talking about a solution, and really what Håkan and I always talk about is there's angst, there's suffering, and then there's always a workaround or a solution of some sort to make it better. And I feel like I'm MacGyver. And by the way, MacGyver went to my college where I graduated from. He always wore that St. Cloud State jersey. That's where I played. So I'm a MacGyver fan. Anyway, you got 15 minutes, and then you make sure you catch this last breakout session today. And then after that, there's a happy hour slash, we're going over to see the group of industry folks over there, our partners. And that goes on at 4:30, so don't forget to miss don't miss the exhibitor showcase. Again, happy hour with that. And then after that, linger, the wonderful property. You got some free time. Find and chat with Deborah and I or whoever. Find a